So I'd like just to remind everyone that CBER has regulatory responsibility over biologics, which include vaccines, blood and blood-derived products, cellular tissue, and gene therapy products. With respect to the Sentinel program, the component of the Sentinel program that focuses on surveillance of vaccines is called PRISM. That component for blood is BloodSCAN, and we use General Sentinel for cellular tissue and gene therapy products. This is a list of current priority areas for the CBER Sentinel program. First, expansion of hemovigilance capabilities, signal refinement and evaluation of vaccines and blood through use of both claims data as well as electronic health records, safety of vaccines in pregnancy, signal identification of vaccines using the TreeScan method, and vaccine effectiveness activities. So as I give an update on the current and recently completed activities of CBER Sentinel program, you will see examples in each of these areas. So again, just to remind you that currently we have two instruments to do our surveillance work and interrogate Sentinel database. One is the rapid query tools, or ARIA, or modular programs that you heard about this morning. And also we have protocol-based activities, which we categorize into three groups. We have infrastructure building, methods development, and product assessments. So I would like to shift the focus now on an update on some of our recent activities within the CBER Sentinel program. You heard quite a bit about use of rapid query tools from previous speakers this morning. So historically, CBER did not use these tools regularly. But as of last year, we have started to use these tools, and we will expand the use of the tools because they are more sophisticated and they can answer many questions in a relatively timely manner. So as of last year, we have used all levels of these rapid query tools, and we will continue the use. Most of the activities of the CBER Sentinel program have been in the area of protocol-based activities. So this is a list of the protocol-based activities that we have completed in the past year, which they fall in categories of methods development, infrastructure, and product assessments, all three categories. Here we have a list of our ongoing activities with respect to protocol-based activities, and this is just a snapshot. So I mentioned that vaccine safety in pregnancy is one of the current priority areas for the CBER Sentinel program. Because most of our data are claims data, we have to build certain pieces of infrastructure within the Sentinel system and the capabilities to be able to carry out these studies with respect to pregnancy. For example, we need to be able to identify pregnancies using certain algorithms, or sometimes to link mothers to their babies, or determine the gestational age. So in order to be able to make these take these progressive steps and carry out pregnancy studies, we need to build the infrastructure. So here I'm showing an example of such an infrastructure which falls in the category of a protocol-based activity with medical chart review. And we selected a test case for this study. So the exposure is inactivated influenza vaccine, and we have a couple of outcomes: spontaneous abortion versus live birth, and oral cleft in newborns. Now, the selection of oral cleft was not the result of having any concerns or any evidence in terms of potential association between flu vaccine and oral cleft, but it is an easier outcome to identify in claims data, and that's why we selected this outcome. So this study has two main objectives. First, the idea was to build the infrastructure and develop the methods to examine pregnancy outcomes and birth defects after vaccination, and also more specifically examine positive predictive value of claims-based algorithms for spontaneous abortion, gestational age, and oral cleft. So with respect to spontaneous abortion and gestational age outcomes, the project is almost completed. We are finalizing the study report to be posted to the Sentinel website. With respect to the oral cleft outcome, medical chart review is close to completion. Another area of priority for a CBER Sentinel program is use of signal identification methodology. And the method that we are using currently is TreeScan, which is developed by Martin Kulldorff. And TreeScan looks for unexpected adverse events. It detects excess risk of adverse events that are grouped into some hierarchical tree structure of diagnostic codes. So in this area, we completed a pilot project using the human papillomavirus 4-valent, and currently HPV-9 vaccine analysis is underway. We are also expanding the capabilities of TreeScan to be able to include longer-term and variable follow-up periods, and also do power calculations. So now moving on to our BloodSCAN program, which is focusing on the surveillance of blood and blood-derived products. And again, signal refinement and evaluation of blood is another priority area for the CBER Sentinel program. So BloodSCAN has two sources of data: claims as well as electronic health records, mainly addition of the new data partner to the Sentinel program, which is Hospital Corporation of America. Now, each of these data sources has its own limitations and strengths, but it should be noted that access to inpatient blood transfusion data certainly broadens our capabilities for blood safety surveillance. I'd like to highlight two of our projects in the BloodSCAN component. One is intravenous immunoglobulins and thromboembolic events, which Scott mentioned, and I will not go into details about that. And the other one is transfusion-related acute lung injury. Both of these are protocol-based activities with medical chart component. So transfusion-related acute lung injury, or TRALI. This is primarily an infrastructure building project. We use this project to become familiar with the HCA database and learn how to use this database. And we added a test case of TRALI assessment to it with the objective to evaluate incidence rate of TRALI after plasma, platelet, and packed red blood cell exposure. We posted the protocol to the Sentinel website in September of 2016. TRALI cases have been identified in the HCA database, and medical chart review, medical chart retrieval and adjudication is underway. We have embarked on a new area of activity within the Sentinel program, and that is vaccine effectiveness. This is, again, a priority area, but a new priority area for our Sentinel activities. And we have started a pilot project. The idea for the pilot project was to assess use of Sentinel capabilities for effectiveness evaluation in a limited capacity for specific situations. So my colleague, Dr. Maria Said, will be presenting on this pilot project, and I will not go into details about it. So I'd like to highlight the major accomplishments of the CBER Sentinel program in the past year. The use of rapid queries is a significant step for us because they are now more sophisticated. We have integrated Sentinel into our regulatory process and have a much more active participation of our pre-market offices with the program. We have transitioned from development to production mode and also initiation of vaccine effectiveness activities. So the question is, where are we going with all of this in the future? So as I said, we will be focusing less on protocol-based activities and more on use of the rapid query tools, or ARIA, specifically for product safety assessments. But we will continue to expand our activities for infrastructure and increasing capacity. In collaboration with the Sentinel Operations Center and our pre-market offices, we would like to work towards making the Sentinel program more efficient. And two of the areas of improvement that we have identified and are currently working on are reducing our data lag and also exploring alternative data sources such as electronic health records to claims data because of the limitations that claims data bring to the table. So in summary, CBER Sentinel program has made significant accomplishments in the past year. Availability of the sophisticated tools has led us to use these tools to interrogate Sentinel database, and we will continue to expand that use. We have incorporated vaccine effectiveness activities of Biologics into the Sentinel program in addition to safety. And finally, integration of Sentinel into our regulatory processes and the transition from development to production mode have made it possible for Sentinel to make bigger contributions to the safety of medical products and ultimately to public health. I would like to acknowledge a very large group of people behind the scenes who have made this work possible, and I'm presenting on their behalf, including Sentinel Operations Center at Harvard Pilgrim, our data partners, my team, CBER Sentinel Central Team, and other folks at Office of Biostatistics and Epidemiology, and pre-market offices of CBER, and our Sentinel investigators and collaborators across many institutions. Thank you.
Good morning. My name is Maria Saeed, and what I'm going to do today is just spend a little bit of time presenting a project that we've been doing in CBER, which is really trying to assess and explore whether we can conduct vaccine effectiveness surveillance in Sentinel's PRISM program. So the rationale for this project is that PRISM, which is a part of Sentinel and uses a subset of Sentinel data partners, is an incredibly valuable and rich resource. There are a large number of members from wide, geographically diverse areas, and there are multiple potentially useful data elements. There is demographic data, there is outpatient pharmacy dispensing, and there is outcome data, including dispensing codes, diagnosis codes. So the question really was, can this be used for another purpose? If it's been used already for successful vaccine safety studies, as has been done with influenza and febrile seizure study, rotavirus and intussusception, if it's been used for these safety studies, why not also for vaccine effectiveness? And although our regulatory decisions really rely on randomized controlled trials, we thought that PRISM's observational data might be able to supplement the data from these trials under certain circumstances. So the question really for us at the beginning was, what gaps are currently there and what gaps could PRISM potentially fill? So first, in certain situations, for confirmation of effectiveness for vaccines approved under accelerated approval or the animal rule, this might be an opportunity for PRISM. And to explain this more, unlike traditional approval, which provides direct pre-licensure evidence of effectiveness by demonstrating protection against disease, or in some cases, through use of a scientifically well-established correlate that predicts protection against disease, there are some vaccines that are approved through accelerated approval or the animal rule approval, and these either use a surrogate endpoint or animal models to predict a clinical benefit. Both of these other pathways require a post-marketing study to further assess the vaccine's safety and effectiveness. So a second gap that we thought PRISM might be able to fill was the evaluation of effectiveness in specific populations. Within these large randomized controlled trials, there may be data, but they may not have sufficient data on small subsets. For example, a gender or a age group. Another gap that we thought PRISM might help us with is in evaluating effectiveness to prevent rare conditions or a more specific endpoint. So for example, hospitalization or severe disease. There are also situations in which a randomized control trial is not ethical or feasible. And I think with the Ebola vaccine, I think this question came up, where we had a situation in which essential public health measures, as well as the ethical concerns of conducting a trial, really raised the possibility of what other studies could be done. And then finally, I think that there's a gap in terms of supplementing or confirming what has already been learned in a randomized control trial. And we have a precedence for this with high-dose versus standard-dose influenza vaccine, in which there was a clinical trial, but an observational study was also used to sort of supplement and help us better understand the data or the situation. So given this background and given that these gaps that we recognize, our objective in this project, which began in June 2015, was to address the suitability of using PRISM to estimate vaccine effectiveness. The project really had two components. The first part was an overview of study designs and methods used in vaccine effectiveness studies, with particular attention to observational studies that used administrative databases. And then the second part of our project was really to explore the PRISM database through a use case. This project was done in collaboration with the Harvard Sentinel Operations Center, as well as a number of vaccine experts from around the country. So as we kind of delved more into this project, we realized that we needed sort of a roadmap in trying to figure out how to assess vaccine effectiveness or the potential of doing vaccine effectiveness studies. And so what we did is we really divided our thinking into 4 different parts. We thought first about data elements. So what kind of study population do we have? What kind of exposure data do we have? Are we going to be able to assess whether someone's been vaccinated or not? What kind of outcome data do we have? Do we have laboratory or other diagnostic test results? What kind of covariate data do we have in terms of socioeconomic status, for example? We also looked at methods, and for this we really looked to other studies that have been done before in observational studies in administrative databases, and we looked at the different study designs and the statistical adjustment methods that they had used. We then also thought about assessments, and really we looked to the vast array of Sentinel and PRISM tools that had already been developed through other studies, through the protocol-based assessments and the modular programs, and looked to see what we could leverage for vaccine effectiveness studies. And then finally, we sort of took all of these and we applied them to a use case. So we kind of imagined a hypothetical study that we might do and started to go through the beginning steps of that study to see how it would actually work out. So for our use case, we based our thinking around a study that's already been published. This was a paper by Dr. Hector Izureta looking at the comparative effectiveness of high-dose versus standard-dose influenza vaccines in U.S. residents aged 65 years and older using Medicare data. It's an administrative database. It's Medicare data, but it was a question around vaccine effectiveness that we thought we could apply to thinking about Sentinel as well. And so really the question was, if this study could be done in one large administrative database, could it also be done in the PRISM database? So to clarify, our goal when we did this was not to actually come up with a measure of effectiveness for high dose versus standard dose influenza vaccines. What we were really doing was using this as a guide to start to explore the availability of data elements and really to better understand what exposure data we had, what outcome data we had, and what covariate data we had. We did not actually determine the association between the exposure and the outcome. Our goal really was to be able to produce a table like this and to see what kind of data elements we had. And so when we go back thinking about the 4 different ways that we sort of approached this project, the first one was looking at data elements, and we looked into Sentinel and what was available. And what we knew is that it's an incredibly large database, and it covers a very wide geographic area. But in terms of age distribution, because people over the age of 65 are covered within Medicare, we didn't have as much data on the older patients within Sentinel as we might in, say, Medicare database. Also, in terms of representatives, we had data for privately insured patients, but we would not necessarily have information for patients who are not privately insured. So that's just one example with study population, but within this data elements thing, we looked at multiple things in terms of exposures and outcomes. So in terms of thinking about methods and study designs, what we did for this is we conducted a literature review, and we also asked for the help of a number of vaccine experts from around the country to really think about what has been done before. And we looked at previous studies that had been done and developed this table. And I'm just showing you an example here where we looked at the study design, cohort study for an example, a description of what that study was, and then thought about how it would be applicable or not applicable within Sentinel. And based on that, we came to a determination of whether it would really be viable. And then we went through a number of studies so that we could have examples that we could pull from if we went forward with any of these study designs. Third, we looked at the assessments and tools, and really what we were trying to do here is leverage all of the work that's been done before. Here is just a schematic of the toolbox and that has been developed by the Harvard Sentinel Operations Center, including programming for modular programs and other analyses. And I don't want to speak about each one of these, but I'll point, and there's more than what's listed in this picture, but what I want to do is point out to the one at the bottom, the Cohort ID and Descriptive Analysis tool, or CIDA tool, and this is just the tool that we used when we went through our use case. So finally, we actually went through our use case, and what we found is that we were actually able to obtain information and generate tables. We were able to determine the number of patients who had received high dose versus standard dose influenza vaccination over years. We were able to identify the numbers of episodes and patients who had been diagnosed with influenza or pneumonia. And in this part, we actually explored different ways of determining the outcome. So for example, for influenza diagnosis, we used the ICD-9 diagnostic code, but we also used an algorithm looking at whether someone had had an influenza lab test followed by oseltamivir prescription a few days later. And then we were able to understand better the patient characteristics, including age, sex, medical history, and other covariates. So this is a project that's very much, we're in the middle. We have a draft white paper that has been interesting and fun to work on with input from a large number of people. It's currently, we have a draft and revisions are ongoing. When that's completed, the white paper will be posted on the website. This has been a project in which a number of people have been involved, and I want to thank everyone, as well as people who initiated this project. Thank you to them as well. So this is a very big collaboration, and it's been really interesting to be part of. Thank you.
Great, thanks, Maria. Next, we'll hear from Richard.
I'm sorry, where are my slides? Ah, got it. Good morning, everyone. I'm Rich Forshee. For those of you keeping score, I'm Rich number 3 on today's agenda. It's actually a personal record for me. I've had more than 3 Richards, but this is the first time I've had 3 Riches on the same agenda. My presentation is going to be a little bit different than some of the other things we've seen this morning. The goal of my presentation is to give you a richer understanding of some of the kinds of activities we engage in at CBER, and in particular some of the kinds of benefit risk assessments that we engage in, and to try to let you see some of the special needs that we have when it comes to using health claims data to inform some of those benefit risk assessments. As a number of other speakers have already mentioned this morning, CBER is responsible for regulating vaccines, blood and blood products, and cellular tissue and gene therapies. These products really have a very diverse set of benefits and risks. I'm going to ask you to consider 3 examples that you may have seen in the news recently. Last year, around this time, we became aware that there was an outbreak of Zika virus in the U.S. territory of Puerto Rico. And we were also learning at that time that pregnant women who became infected with Zika were at increased risk for having a child with microcephaly. This was a very big public health concern for us, and within CBER, the specific public health concern that we had is that Zika virus can be transmitted by blood transfusions, and so we wanted to get a better understanding of what the risks in Puerto Rico would be. I'm going to talk about this example in more detail later. Another issue we've been dealing with over the last couple of years is how to manage the risk of transfusion-transmitted HIV, and in particular what the appropriate donor restrictions are for men who have had sex with men, and that policy has changed over the year and has received a good bit of public comment on what we should be doing there. And just a third example is monitoring the safety of flu vaccines. We know that there have been some flu vaccines for which there's been an association with an increased risk of GBS, but this needs to be balanced against the many known benefits of flu vaccination. This is just to give you an idea of the range of the kinds of benefit risk assessments that we need to address within CBER. Sentinel data can help a lot with allowing CBER to accomplish our public health mission. I'm going to talk about 2 examples, the transfusion transmission of Zika virus and testing strategies for the U.S. blood supply for transfusion-transmitted Babesiosis, in order to give you an idea of how data from Sentinel could help in these activities. Just for a little bit of background on blood donation is common and it provides multiple life-saving products. To give you an idea of the numbers we're talking about, in 2013 there were more than 14 million red blood cell units that were collected from donors, and there were about 13 million red blood cell units that were transfused to recipients. So we're talking a large number of procedures. In addition, blood donations are also the source for other blood products, as Scott mentioned in his presentation and Maria briefly mentioned in hers. I'm sorry, I guess it was Azadeh who briefly mentioned in hers. Blood donations are the source for immunoglobulin products. They're the source for clotting factor products, and the source for other products as well. So in the first example I'm going to talk about, I'm going to show how Sentinel was able to help us a great deal by providing timely data to support benefit risk assessment for the outbreak of Zika virus in Puerto Rico. As background, we know that that there's local transmission of Zika in more than 59 countries and territories. We know the risk of microcephaly associated with infection during pregnancy. And we also know that there is a risk of transfusion transmission of the Zika virus. According to recent FDA recommendations, we have travel-based donor deferral and testing of blood collected in areas with active local transmission. These guidance went in place in February of last year. The specific issue that we were facing about this time last year was the virus outbreak in the U.S. territory of Puerto Rico. As of March of last year, there had been 372 known cases of Zika virus transmission. Since then, as of about a week ago, there have been almost 35,000 laboratory-confirmed Zika cases in Puerto Rico. The outbreak as of last year was of sufficient concern that blood collection in Puerto Rico was temporarily suspended at the start of that. There was a 6-week suspension, but this was not a sustainable policy. And so during this time, the FDA was investigating whether a nucleic acid test under IND could be an appropriate risk management activity. And after the nucleic acid test for Zika virus received IND but not licensing, after it received IND approval, local blood collection resumed, and there was testing with gnats since April 3rd of last year. We wanted to know if this was going to be sufficient for risk management, so we wanted to conduct a risk assessment for how this would reduce the risk. And one of the things that we particularly wanted to know was what was the baseline risk for pregnant women with regard to transfusion-transmitted Zika virus, and what was going to be the risk reduction for this particularly important subpopulation. But we had a problem. Nobody knew what percentage of transfusions went to women who were pregnant. This is where the Sentinel team came in, and I can't thank the Sentinel Operations Center enough for the rapid turnaround, and Rich Platt talked about this earlier. The data phase was only about 3 days, but even the phase of getting the question right and getting the query right was done very, very rapidly. Any risk assessment has many inputs that are required. I'm only going to focus on one input in this case, and that was the transfused units for pregnant women. Again, we didn't have this data when the Zika outbreak occurred in Puerto Rico. Using Sentinel, we were able to quickly get an estimate. We weren't able to get an estimate specifically for Puerto Rico, but we were able to get an estimate for the U.S. as a whole and apply that to Sentinel. So Sentinel provided a key input for a risk assessment with important public health implications. There were several outputs that we looked at in that risk assessment. For today, I'm only going to focus on the transfusion-transmitted Zika risk for pregnant women. Our model had predicted a baseline risk of slightly more than 5 transfusion-transmitted Zika cases to pregnant women for the period April 3rd to November 17th, which was when we were seeing the most transmissions. And our model, based on sensitivity that we saw from the individual donation NAT test, showed we'd reduce that risk by about 86% down to less than 1 predicted transfusion-transmitted Zika for pregnant women in that time period. Let me move on now to the second example of how health claims data can support the kinds of risk assessment work that we need to do at CBER. And I'm going to illustrate this by showing how we use geographic data for a benefit risk assessment for transfusion-transmitted babesiosis. For those of you who aren't aware of this particular disease, Babesia microti is a parasite. It's a tick-borne, babesiosis is the disease. It's a tick-borne disease. And one of the reasons that this is particularly difficult for blood transfusion is that people can be chronically infected with babesiosis and not show any symptoms. And in fact, most of the people with babesiosis are not going to be symptomatic. So they can show up to donate blood, they can feel fine, nothing will show up when they're asked about how they feel that day, but they could still have the parasite in their circulating in their bloodstream, and it could be transmitted to people who are at risk of the disease. There's a number of reasons this is important. Currently, we don't have a licensed donor screening test available for the parasite. It's one of the most frequently transfusion-transmitted infections that we observe in the United States. there's a couple of complicating factors because this is a regionally located disease. Most of the babesiosis cases occur in the Northeast and upper Midwest. However, we see them across the United States because you can become infected in New England and then travel somewhere else and give blood. There are tests. There's a possibility that we will see some tests for the parasite available in the future. And so we wanted to better understand how we might be able to implement this when the tests become available. Last thing about the disease I want to mention is that while for most people it can be asymptomatic or very mild, for neonates or someone who has a compromised immune system, it can be fatal. And so even though it's mild in most cases, for some individuals it can be very severe. So I mentioned earlier about the distribution of the disease, and you can see that the concentration is primarily in New England, a lot in the upper Midwest. There's also a number of cases in California. However, that's a different subspecies of the parasite that we see in the California area. So in 2015, OBE in close collaboration with OBRR conducted a risk assessment of transfusion-transmitted babesiosis. This was presented at the Blood Products Advisory Committee in 2015. This did not use CMS data. This did not use Sentinel data. Instead, we used data from the Center for Medicare and Medicaid Services to evaluate the testing scenarios. I'm not going to go into detail on this map. What I'm showing on this slide is the different scenarios that we investigated. And the point is we looked at scenarios that would focus the testing just on the region with the highest incidence of babesiosis. And then we looked at several different scenarios that incorporated more and more areas of the country where we were seeing cases of babesiosis, all the way to an extreme scenario where we were doing serology and NAT testing in all 50 states to show the range of possibilities that we had for implementing tests for the parasite. And again, I'm not going to go into detail on this slide, but this was our way of trying to summarize what we learned from this analysis. We looked at 4 key outcomes: the risk reduction for transfusion-transmitted babesiosis from the baseline of no testing, the number of positive units that were interdicted, the positive predictive value of the testing, and the number of donors with false positive results. And the point that I want to emphasize here is that we were able to demonstrate what trade-offs there were between risk reduction and reduced positive predictive value as you expanded the number of states in which you were conducting the testing. So this analysis was very useful for the advisory committee to discuss where that line should be drawn. It also showed the importance of having information on the geographic distribution of an emerging infectious disease. And this could also apply to other conditions that have a geographic component as well. This data on geographic distribution can be very important for informing our regulatory decisions. As I've shown here, we do have successful examples using CMS data where we were able to get highly detailed data on the geographic distribution of a disease that we were concerned about. However, one of the criticisms that we received for this modeling exercise was that the CMS data is primarily people who are more than 65 or older, and there was a question of how representative that was for the entire population. This is an area where data from Sentinel could be a very useful supplement to the kind of data that we used from CMS. So for certain projects, Sentinel data that included geographic information could be very helpful for the kinds of public health issues that we address at CBER. I also want to mention that we recognize that geographic data can be sensitive, and in particular we want to avoid any small cell counts that may occur. So we certainly recognize the need to aggregate up to appropriate geographic levels, such as 3-digit zip codes, and to work with the data partners on any other concerns that there may be about sharing data that's got geographic information. But that said, it's something that could be very useful for some of the issues that we face. So in conclusion, Sentinel data has already been useful as inputs in CBER benefit risk assessments. We greatly appreciate the value that the Sentinel data has already provided for us, and the SOC has been great to work with, especially in situations where we have a time-sensitive outcome. They have been very responsive. And we continue to explore other ways that the Sentinel data can help us to accomplish our health mission. None of this was done alone. We had very large teams working on both of the risk assessments that I discussed. Some of the Zika risk assessment was presented a couple of months ago at the Society for Risk Analysis meetings, and the Babesiosis risk assessment was presented at the Blood Products Advisory Committee meeting in 2015. I also got very useful feedback on my slides from several people in OBE, including many people who are in the audience today. So with that, I want to thank you very much for your attention and look forward to discussing this further during the panel discussion.
I'd like to thank all of the presenters. These were wonderful examples of how Sentinel can be used to further the public health mission of the activities within CBER. So I'd like to open it up to the room for questions and answers, so start thinking. I do have a few questions of the group before we turn to that. All of you had wonderful examples of how Sentinel is useful. Maria, you pointed out in terms of looking at vaccine effectiveness, a couple of examples of how the Sentinel infrastructure might be useful. You talked about potential use in confirming effectiveness results after an accelerated approval. Looking at effectiveness within specific subpopulations that may not have been teased out within the clinical trial data, rare conditions, potentially new endpoints that weren't studied in trials, but there might be opportunities within the infrastructure. So my question, and you provided also a good example of, well, let's see if the results that you do within this system compare to a previous study. So Hector's paper was a good example of comparing that. The question is, do you foresee the need or any value in also comparing what you can generate in terms of evidence from this infrastructure to what was learned from clinical trials? So do you see that as an important step to maybe further using the system for effectiveness?
So I think the way that we view the observational studies that can be done in Sentinel when we're talking about vaccine effectiveness is that they can supplement the work that has been done for randomized control trials. There are, the burden, the regulatory requirements really lie with the randomized control trials, and so we don't see the observational studies as a substitute, but we really see them as something that can add to what we already know. So I think in the case of high-dose influenza vaccine and standard-dose influenza vaccine, there was a trial that was done, and then subsequent to that, there was an observational study, and the observational study found results very similar to the clinical trial, and that just increased our confidence in the information that we were receiving.
If I could build
sure,
on
please,
that just a little bit, I think the only thing I would add to those comments is that the observational data also can help to show what's happening in the real-world use of the product, and so it can give us a better idea when it's being used among a broader set of people that may have used the product during the clinical trial.
I guess so. So, sort of a follow-on to that, and is related. As we know, part of the 21st Century Cures Act was a provision that enables FDA to start looking at the potential uses of real-world evidence in regulatory decisions. And one of the examples that was at least spelled out in the legislation was, products already on the market. Is there a potential for real-world evidence to support updates to the label or new information to be included in the label? And I'm not going to ask you about, can that be done? But as you've begun to look at the Sentinel infrastructure and its potential use and looking at vaccine effectiveness, what are some important gaps in terms of the data capabilities or in terms of the methods do you think would be in sort of high priority areas to consider or to continue to look at and improve in order to potentially use this type of a system or real world data for label decisions? So the question isn't can you do it, it's more in what you've been learning about the methods and about the data, what are high priority gaps that still need further looking at?
So I think, there are some differences between safety and effectiveness studies in general. One of the things that we have run into is the outcomes for effectiveness. A lot of times having laboratory data or diagnostic test results such as a chest x-ray or a CT scan, that information would be very valuable. And I think that's something that is currently being worked on, and I think that having that information would be valuable in terms of the outcomes we look at for effectiveness. So that's one area where I think that we've identified a potential gap.
So if I can follow
Sure.
on that, Maria's absolutely right that is critically important, being able to accurately identify both the exposures and the outcomes, and sometimes that can be difficult to do with claims data alone. Another issue that we struggle a lot with when we're working with observational claims-based data, we don't have the luxury of randomization in this case, and so we need to take great care to make sure that we're getting the best comparison groups that we possibly can and have the best matching when we are designing the protocol for the study that we're doing. So that's something that requires a great deal of attention in the early stages of the analysis. I think another thing that's important is to very carefully consider the remaining potential sources of bias that you perhaps weren't able to address while developing the protocol. The best thing to do is to address as much of the potential sources of bias in designing the study as you can. If there are things that can't be addressed at that time, you should consider them very carefully, and one of the things that we're building towards is being able to not just do a qualitative evaluation of those potential sources of bias, but as much as possible to quantify how much potential sources of bias that we weren't able to address in the design, how much could they really affect the findings, and how big an impact could they really have on the decisions and the actions that we take as a result of that study. So I think those are a couple of other things that I would add as considerations when thinking about how to use results from data like Sentinel as a source of real-world evidence for making decisions.
Great. So we have time for questions from the audience. If you do have questions of our panelists or comments about the presentations, please join us in the aisle. There are a few microphones. As folks are thinking of questions, one additional to the full group, but Azadeh, you really laid out a lot of activities over the last year within CBER, and sort of the significant focus on protocol-based assessments in areas of improving methods, improving infrastructure, and then actually doing product assessments. So the sort of overall question to you, like any surprises as you were doing studies in any of these three areas? What really jumped out at you as a really important lesson learned, or results that you didn't quite expect but were somewhat of a surprise? Any comments on that?
fortunately or unfortunately, however you would like to look at it, we have not had any surprises, but there have been many lessons learned from these, particularly infrastructure building and methods development activities. For example, one of the areas where we are faced with some challenges is the study of safety of vaccines among pregnant women. Linkage of mothers to their infants has been done using the Sentinel system, but it is a relatively challenging process and takes time. So that's one area. Using ICD codes and other codes available within claims data for determining the gestational age is another challenging area. Sometimes, as Maria mentioned, because we don't have access to laboratory results data for a large proportion of the Sentinel population, not having the laboratory results and just having the order of the tests sometimes creates challenges for some of our detection of some of our outcomes. So there are, as we do these more customized studies, we are identifying the challenges, but also we are gradually working towards resolving these challenges. For example, for detection, identification of pregnancy or gestational age, we have been told that use of ICD codes, which are ICD-10 codes, which are much more granular, might help us with these two issues. So overall, there are challenges, and we will gradually be able to resolve some of them, and some of them will remain as challenges.
Great, thank you. Hector?
Yeah, thanks for the presentations. I have a question, which is, when we talk about claims-based data, we usually call it limited, and you have shown examples that might be allow us to be a little more creative in the use of claims data. Let me explain. If we go to medical record reviews in a study that started as a claims data analysis, the time we will lose in going there is extraordinary. The resources are extraordinary, and we lose a large proportion of the cases. Maria has shown examples, and Asade has had made comments in that when we have, for instance, a claim for a service, and there is some evidence that something else has been done that with this claim that confirms the fact that at least the practitioner making the diagnosis thinks that the diagnosis has been confirmed, we could use that to get much more rapid evaluations of effectiveness. Maria has used an example of defining influenza by a consultation followed by a treatment specifically with oseltamivir. By at least you are proving that the physician who was treating the patient believed this was influenza. We did recently also a study on herpes zoster in which we use similar consideration. Herpes zoster treated specifically with drugs that are antivirals against herpes zoster. They give us an evidence that the practitioner believed this was the case. And then we could do medical record review in a subset of the cases just for confirmation of the predictive value. I could go on, but the thing is, I do believe that we can get much more rapid assessment of effectiveness and also of safety by trying to get deeper into the claim and how the claim system works and use that knowledge to get more rapid results. Do you have any feedback on that and experiences you would like to discuss?
I think the laboratory test results is an example that comes to my mind, that a proportion of our data partners have laboratory test results, and this is still within the confines of the use of the claims and administrative data, that for that small population, if there are special conditions and situations that we can use that small population with the laboratory test results, that would certainly add to some of the capabilities for certain types of studies, whether it's safety or effectiveness, that we can use.
And I would just add that I think this is a promising area for a lot more methods development and trying to really, we have a range here from, we just see an ICD-9 code in claims to we've done a careful evaluation of all of the medical charts, and we have a very, very high degree of confidence in the accuracy. And Hector, I think what you were pointing out is there's a very rich field between those two areas. And I think, and others have been doing some work in this field, but I think there's more work to be done to understand what the trade-offs are in terms of being accurate, capturing the most true cases that you can, cost, time. These are all things that could be considered in thinking about the range of ways of identifying cases, and I think it's an area for further research.
This is ending up being a CBER discussion, but just remember what the experience was during the advisory committee for babesiosis was. There was a huge demand that medical chart review be done for case confirmations. So that was an important part of considering how we do these types of studies in the future. So making high impact decisions, people want a level of accuracy, and that chart review really does give you at least some confidence in that diagnosis. So it's important.
Great. Thanks for those questions, and I appreciate the burden and resource-intense activities of doing chart confirmations, particularly when a lot of the charts are paper-based and need a lot of resources to go and review. So it needs to really be a subset. And hopefully, as we've heard in this session and in earlier sessions, that much can be gained by bringing in more electronic health record data or other clinically rich data that are electronic and might help to reduce the traditional resource intensity of actually going to paper-based medical records for confirmation. So hopefully that can help improve efficiency when you do need to go back to the source of the data. So that brings us to the end of this session.